I'm now going to welcome Seth Sherman to the stage to talk to us about his approach with scaffolds, cells, and allografts. Thanks, Seth.
Thanks again. That's obviously a very tough act to follow. Thanks, Tim, for the honor to follow Bill Bugbee. My task here today really will be to try to give you show you what the landscape is across the world in the cartilage space, and then try to tie in an algorithm that will make sense to you in your own practices. So the problem that we all have is that the treatment algorithm that we'll go through is complex, it's confusing, and it's constantly evolving. Been involved in trying to make algorithms and work with mentors over the years, and it just continues to change. And so I think it's just important to recognize that not all cartilage patients are the same. There's lesion-specific differences as far as size, location, as far as tibiofemoral, patellofemoral, depth of lesion. There's also joint and limb-specific differences. So very different for me, someone with pristine x-rays versus someone with early narrowing, early osteophytes, or frank arthritis. The treatments are different. And we've talked a lot about alignment and stability. And then there's patient factors like age, BMI, activity, compliance, expectations, and certainly insurance status. So there's really no one-size-fits-all treatment for our patients. There are multiple options for small focal defects. We'll go through several of them, the pros and cons. But when it comes down to it, there's really limited options when we talk about large, multifocal, or lesions of the patellofemoral joint. We're really talking about osteochondral allografts, and we're talking about cell-based cartilage repair, most specifically MACI. And so when we try to wrap our head around this, you can really look at the differences between the easier, cheaper single stage versus the more difficult, expensive, or two-stage, and we can kind of map that out with regard to the type of healing we're expecting, fibrocartilaginous tissue, hyaline-like, or actually mature hyaline. And so I think that's very useful to keep in mind. For me, we looked at this and presented at ICRS. We looked at all the commercially available cartilage procedures stratified by the FDA regulatory pathways. And what really stood out to us is that ACI and osteochondral allografts, as you see here, demonstrated the greatest number of preclinical and clinical articles supporting their use. Not really a surprise to those of us who are in the space, but look at all the other ones. And I think it's just important to really have perspective when we go out and we look at the national meetings, or we go even here and see, really critically ask what the preclinical data, where's the clinical evidence? And if you want to practice evidence-based medicine, then you can see where the studies lie. So if you're considering a single-stage cartilage repair strategy, I would implore you to know before you go. That means you need to make sure you have mechanical axis views, long leg views. You need to know the alignment. You need to correct all these other factors. So I think what this boils down to for me in my practice is don't microfracture in varus. I see that almost every week, and I need to do HTOs and or OC allografts on these patients, almost monthly to get them out of very bad jams. I do have concerns about marrow stimulation. We can discuss them. We talk about durability of the repair, longevity of these results, and return to play, as we'll see, versus OATS autograft or versus osteochondral allograft. The results when you get bigger than 16, 18 millimeter diameters are inferior in multiple studies. I think that if it's small, well-contained, acute, younger, so ideal candidates, if you're using a drill over a pick, if you're going smaller and deeper, if you consider augmentation as you have available here, and you stick to the rehab very compliantly, then I think you have the opportunity for a good outcome. There are several products. We can't go through all of them, but there's evidence out there, at least for BST Cargel. There's preclinical and some clinical data. For biocartilage, you can see this is Lisa Fortier's work in an equine model, so you can see without and with the biocartilage after microfracture. And then also recent studies looking at AMIC procedure, randomized controlled study, which is great compared to characterized chondrocytes with no differences in those groups, but still a more recent systematic review demonstrating that there's really a paucity of high-quality RCTs testing these microfracture plus strategies versus other gold standard techniques. And so can we say if we can expand the indications for marrow stimulation based on our data, improve the durability of the repair, or accelerate our rehab? I really don't think we're there yet. So I would continue to learn and continue to study this. But we'll kind of pivot now to cell-based cartilage repair. So this is using cells with or without a scaffold to effect repair. This can be either autograft, such as Macy or minced cartilage, or allografts. We'll talk about particulated juvenile allograft, which we have available in the United States. So there is evidence for particulated cartilage repair. These mechanically minced cubes could affect repair. They basically have the chondrocytes that can escape. They can form new matrix that integrates with the surrounding host tissue. And so when you look at this, there is biosynthetic activity, juvenile superior to adult autograft, but both actually can get the job done when we're talking about collagen and GAG production. There are animal models for particulated juvenile allograft and also for particulated adult autograft that show good response, as you see on the bottom here. The FDA considers this minimally manipulated human tissue. So basically, there are favorable in vitro animal models, as I showed you. There's limited but growing outcome data, but we're able to use this in America, and there are several thousand cases. I think the bottom line is that these are all small case series. They're all small to medium-sized lesions, so there were not large defects. But they did show good to excellent subjective outcomes and good defect fill. There's other single-stage procedure. This was published in AJSM. This was a study that was discontinued for financial reasons, but it basically was also minced autograft, and you can see the KOOS scores in the pivotal study were actually quite excellent. Martin Lind also has looked at minced cartilage and kind of sandwich-type technique for OCD defects, a small series of 8 with good outcomes in his hands. This is Brian Cole kind of showing harvest of autograft from the lateral aspect of the trochlea and then being able to mince it, mix it, and implant in a single stage. And so this is something of interest in the United States that we certainly need more data on. Alberto Gobi has used hyaluronic acid-based scaffolds combined with bone marrow aspirate concentrate. And in his results, they're similar to ACI and Macy with good MRI, good histology, superior to microfracture. Certainly a less expensive option. And then Dan Saris, Aaron Critch at the Mayo Clinic, just so we're aware, are participating in the RECLAIM study. Again, minced autograft combined with allogeneic MSCs put back in a single stage. And you have, but we do not have, but hopefully we'll have a trial on CARDI1. But certainly these results also look quite favorable. So we'll move to kind of what I have available, which is ACI. It's time tested. It's 20 plus years of experience since Lars Peterson's initial study. It's bone stock preserving, so it does not burn bridges. But it is hyaline-like cartilage, which is a pro when you look compared to microfracture, but certainly it's a con when you compare to mature hyaline that Bill's implanting. It is 2-stage, which I know puts off a lot of people, but as we talked about earlier, most of my patients are 2-stage. These are complex problems. We need to do staging arthroscopies. Some of them fall out of the algorithm and don't need complex or expensive procedures. Some will have osteotomy initially and not need cartilage or meniscus transplant at all. So I think you can take that for what it is, and it certainly is very expensive, more expensive than osteochondral allografts. But if you're looking for evidence, there's a long track record, multiple publications, 4 large lesions, favorable clinical outcomes, up to 20 years with patient satisfaction, 90+%. This has been a workhorse for many doctors for large femoral lesions of the trochlea and the condyles. This has also been a workhorse for multifocal lesions like you see here. Patellofemoral used to be off-label with the FDA, but now we can use it for unipolar and bipolar defects. And as I told you earlier, we had recent FDA approval for Macy, thanks to Dan Saris and the Summit trial that came out of Europe, showing superiority versus microfracture at 2 years, but now extended out to 5 years. So this is really our first tissue-engineered cellular scaffold. It has uniform cell distribution and cell viability. For us, this has expanded our abilities and indications as far as being able not just to treat the trochlea or the femoral condyle, but also treating other aspects of the joint, patella, rarely when we have to, tibial plateau. It's certainly technically easier. There's opportunities, as Jay Ebert in Australia is teaching us about opportunities for accelerated rehab, and I think our American experience is showing us that we can go faster than we were in the past. There is data, 21 patients, 12-year follow-up, significant subjective improvements, MRI normal or near normal in 75%. The cartilage fill did correlate with clinical outcome for these. Just of note, there were other trials in this space that did not succeed. So the NeoCart trial was suspended, did not meet its primary endpoint versus microfracture. We are participating in the NovaCart 3D trial, which is a phase 3 at this point. So when do I consider cell-based repair? For symptomatic lesions of the patellofemoral joint, so these medium to large patella and trochlea defects, and for bipolar patellofemoral lesions, and for multifocal lesions, condyles plus the patellofemoral joint, and then for rare symptomatic tibial lesions. I think the best way to treat the tibia is to avoid getting into that mess in the first place. I'm usually seeing these after someone else has either debrided aggressively or done microfracture. This was, I think, during my fellowship with Brian Cole, this was a 15-year-old. She had a lateral plateau microfracture. She had good alignment, stable ligaments. Meniscus was sufficient. You can see this cystic defect. This was a challenging case for us, kind of a arthroscopic assisted debridement, followed by placing the juvenile particulated allograft. And you can basically see MRI healing and the subchondral changes resolve, and she was doing quite well. I think the last time we looked was a year or 2 years out from that. So when do I consider other things? Small lesions of the condyles and the trochlea. That's where we really can come into play with Oates autograft, particularly if these are 10 millimeter defects, or for us, fresh pre-cut allografts that are either 10 millimeters or 16 millimeters have really come into our algorithm in the last year and has changed the landscape as far as what we do for some of these types of lesions that you see here. But these are excellent outcomes. Certainly you guys are familiar with the use of autograft. I would say here, this is from the Mayo Clinic, looking at return to sport. When you compare data, there's nothing better if you have a lesion that's perfect for an Oates autograft. 5-month return to sport, 90+%. And you can compare that to microfracture, 9 months, 58%. But as Bill alluded to, allografts, it does take a little bit longer, but the average time was 9.6 months, but it was almost a 90% return to sport rate when they looked at it here. I think for large solitary lesions, at least when you're looking at the evidence, it's dealer's choice, Macy versus osteochondral allograft. I think for us, in our training bias, for me it was more osteochondral allografts than Macy, but you can make a compelling case based on the literature that it's a very reasonable thing to consider. And then just to see that our thoughts are aligned and to bring it back to all of you, when do I consider other things? So older age, early narrowing osteophytes, uncontained lesions, post-traumatic, AVN, OCD, failed prior cartilage procedures, and then the compromised bone bed. So subchondral changes, cystic changes, prior marrow stimulation just has a 3 times higher failure rate for cell-based repairs, and intralesional osteophytes can be a big problem. And so that's where I pivot and more go towards osteochondral allografts in my practice. I just want to close by making you aware of another multi-center and multinational study that's going on with the Agility scaffold. This is quite intriguing. I was a part of this study at University of Missouri, but it's ongoing still. Basically, this is an aragonite scaffold. So it's made of sea coral. You can see the differential porosity, so that basically recruiting to make bone down below and cartilage regeneration up top. You can see histologically what we think is going on is a kind of magnet effect for the MSCs, where they really are adhering to this implant and depending on where they are, kind of changing into the type of tissue that we're looking for. And so the principles are kind of putting this in recessed to the subchondral plate, and you can see cartilage growth and remodeling. I'll show you some examples from the pivotal studies. So this was the kind of first study, and the indications really, it was multi-center, unblinded, but randomized. and it was kind of real-life patients. I mean, these are not just small focal defects. Some of these are bridging the gap towards early osteoarthritis. The study length was 24 months. Here you can see the defects, and instead of having to cover the entire defect like you would with osteochondral allograft, the principle is actually spanning the defect with multiple and smaller of these scaffolds. So technically, it's easier than what Bill showed, and in Bill's hands, his work is very easy, but OCA's, it's a learning curve and it's challenging, and this is much easier, more like an OTA autograft. And so here you can see the MRIs, and you can see the KOOS scores, which really, in my own patient experience, doing 8 of these in the study, I had similar follow-up and similar results to this patient. Just to show you a couple of other examples, the uses are for femur, trochlea, and condyles. You can see the integration on MRI. You can see the subjective scores, which are just, frankly, outstanding. And so for the randomized controlled study, they are now at 96% enrollment. So because of the inclusion criteria, which were broad in real life, they were able to enroll very, very quickly, and they're in interim analysis. So in conclusion, I hope I showed you there are many options for cartilage restoration, but very few with both preclinical and clinical data, particularly for large lesions. I think we all know we have to treat this joint as an organ, and certainly we want to study all of our results because there's a lot more to learn. Thank you very much.